We've all seen it in movies or on the news, right? The flashing lights, the aftermath of an accident, and someone being carefully strapped to a backboard with a neck brace. It looks so routine, almost automatic, but you know what? That decision is one of the most critical moments in emergency care. Today, we're going to pull back the curtain and get inside the mind of a first responder to see how they make that call. It's a powerful image, for sure, but what looks like a simple, standard procedure is actually a really complex question that first responders have to answer in seconds. Who truly needs to be immobilized and who doesn't? And this is where things get super interesting. The old school approach of basically immobilizing everyone with a potential injury, well, that's changed a lot. Modern emergency care has learned that unnecessary immobilization can actually cause its own problems. So the whole process is shifted to a much smarter, evidence-based decision. Okay, so let's put ourselves right there, on the scene. Picture it. You're the first one to arrive at a minor fender bender. A couple of people are walking around, they look a little shaken up, but okay, your first instinct isn't to just grab a backboard, it's to start a careful investigation. Yeah, before any of that equipment comes out, the most important tools you have are your eyes, your ears, and your voice. The whole goal is to build a complete picture of what happened. And that starts with the person and the accident itself. Think of it like a filtering process. And that filtering process, it's all about scanning for red flags, those specific signs that scream higher risk of a spinal injury. Paramedics are trained to hunt for these clues in two key areas at the exact same time. So on one hand, they're looking at the patient's condition. What are they feeling? What are they saying? What does their body tell you? And on the other hand, they're analyzing the accident's mechanism. I mean, what kind of forces were actually at play here? The final decision, it comes from putting the clues from both of those together. So let's dig into that first area, the patient themselves. What are the specific clues from a person's condition that immediately raise the alarm for a possible spinal injury? First up, their mental status. If a patient isn't totally alert, maybe they're confused, maybe they've been drinking, or they're just not acting right, that's an immediate red flag. And the reason is simple, right? You just can't trust their answers. They can't reliably tell you what hurts, or if anything hurts at all. Next are the physical clues, and this is where the specifics are absolutely critical. Paramedics aren't just looking for general neck pain. No, they're checking for pain directly along the midline of the spine. They're also on the lookout for numbness, tingling, weakness, any deformity you can actually see, or if the patient is holding their head in this really rigid, tilted way. Any of these signs, and the risk level shoots way, way up. And finally, there are these reliability clues. Think about it. A patient could have a horribly painful broken leg, and that pain is so distracting, they might not even notice a serious neck injury. Or maybe there's a language barrier, or they're just not cooperating. Anything that gets in the way of an accurate exam automatically puts them in that high-risk category. All right, let's switch gears to that second major category. We've assessed the person, now let's look at the accident itself, what we call the mechanism of injury. This part is all about physics. Certain forces are just known to be especially dangerous for the spine. An axial load, like someone diving into a shallow pool and hitting their head, that's a classic terrible example. Same goes for the violent forces of a high-speed crash or a big side-impact T-bone that just whips the neck and body sideways. And you know, sometimes a red flag is just a number. Simply being over the age of 65 automatically puts a patient in the high-risk category. That's because as we get older, bone density decreases, and the spine just isn't as resilient, making it way more vulnerable to a serious injury. So, here's the absolute bottom line on this part. If a patient shows even one of these red flags, it doesn't matter if it's from their physical condition or from the type of accident, the decision is made right then and there. Spinal motion restriction is happening, period. Okay, but that's the high-risk path. What about the other side of the coin? What happens when a first responder goes through that entire mental checklist and finds, well, 0 red flags? Exactly. This is where the modern approach really breaks from the old immobilize everyone way of doing things. In this scenario, we move to a totally different set of rules to see if the patient can be cleared. And to get cleared, the patient has to pass a very strict 4-point checklist, and they have to pass all 4. First, the accident has to be minor. Second, they have to report 0 neck pain. Third, the medic can't find any tenderness when they check their spine. And finally, they had to have been up and walking around on their own at some point after the crash. It's an all-or-nothing list. And here's a super important exception. These specific low-risk rules have not been validated for kids. This just goes to show you how cautious and evidence-based these guidelines really are. If the data doesn't support it, they stick with the safer, more conservative approach. So let's tie this all together. What does this modern approach to spinal care actually look like? Well, it's a logical, step-by-step process that's all about protecting patients while also trying to avoid treatments that aren't truly necessary. So it really all boils down to a pretty clear two-path system. If you've got any high-risk sign, like that midline neck pain we talked about, the decision is simple. Apply what's called spinal motion restriction, or SMR. But if there are no high-risk signs and the patient checks off all the low-risk boxes, then no SMR is needed. They can be cleared right there on scene. And that term, spinal motion restriction, is actually really important. It shows a huge shift in thinking. The goal isn't just to strap everyone down anymore. It's about finding this crucial balance, protecting a spine that might be injured, while at the same time avoiding the very real problems that can come from being unnecessarily strapped to a board, things like pain, anxiety, and even trouble breathing. So the big takeaway here is that emergency medicine is always learning, always evolving based on the evidence. This smarter approach to spinal care is just one piece of the puzzle. It really makes you wonder, doesn't it? What other life-saving procedures are being re-examined and improved right now, all thanks to new science and better data?